So our presenter this evening or morning or afternoon, depending on where you are, is Betty Ntiamoah. Betty is a midwife with 12 years of professional experience at the Ghana Health Service, and she's currently a lecturer at Garden City University. And so Betty began her career with a diploma in midwifery and subsequently advanced her qualifications by completing a Bachelor of Science in Midwifery, followed by a Master of Philosophy in Midwifery. Her research interests include preeclampsia, anemia, cervical cancer, pain management, and respectful maternity care. She is eager to connect with a potential supervisor to commence her PhD journey. And so as a midwife who strongly values preventive care and the preservation of maternal lives, her aspiration is to positively influence the future of midwifery by ensuring that every woman has access to high quality midwives and comprehensive care. And so Betty will be presenting on her Master of Philosophy in Midwifery project, which she completed in 2024. And so the topic of her project was prevalence and risk factors of anemia among pregnant women in Ghana. So join us as Betty takes us through her project. Over to you, Betty, and thank you very much.
Thank you very much, Dr. Bupe. So as Riley said, my presentation is on prevalence and risk factors of anemia among pregnant women in Ghana. So somebody will ask, why this topic? In a particular district hospital in Ghana, we realized that pregnant women kept coming in with low HBs. And so in the research world, we know that if a research is not done, this will be a mere speculation. And so as a midwife who was thirsty for knowledge and then curious to know what is happening in the world, decided to take this one up and then make it my MPhil project. Next slide, please. So this is the presentation outline. I'll be capturing the background, the problem statements, research objectives, the literature review methods, the ethical consideration, results, discussion, conclusion, recommendations, some references, and the acknowledgement. Next, please. Now, women are dying, and gone were the days when we used to attribute this to the delays. In Ghana, women are now seeking care. And so we still ask, why are these women still dying? And maternal mortality rate is a thing. And we need to find out what is actually happening on the grounds. The three major causes of maternal mortality in Ghana is postpartum hemorrhage, hypertensive disorders, and then infections. Anemia happens to be a secondary cause of maternal mortality because it leads to postpartum hemorrhage in most of the cases. Now, severe bleeding is a complication of anemia in pregnancy, as I said earlier, and then 29% increase in maternal mortality for every 1 gram per deciliter decrease in maternal hemoglobin. Next slide, please. Now, these are some percentages that I found out during this research. So worldwide, the percentage or the prevalence of anemia in pregnancy is 38%. Lower and middle income always takes the major part of this prevalence, and then we all know that Ghana is part of the lower and middle income country, and we recorded 75%. Sub-Saharan Africa was 35.6%, and then Ghana specifically was 45%. Next slide, please. Now for the problem statement. Ghana's maternal mortality rate in 2020 was 776 deaths per 100,000 live births, and this isn't something to joke about. Now, as part of the maternal mortality rates, I mentioned that the major causes include postpartum hemorrhage, and then anemia leads to this postpartum hemorrhage in Africa, including Ghana. Now, PPH is likely to occur after every birth if anemia was present prenatally. And anemia in Ashanti region, where the study was conducted, was 56.5%. Next slide, please. Now, this is the trend of the pregnant women registration, the attendance, the HB levels less than 11, according to the WHO's definition, and then HB less than 7. Now, looking at the trend, in 2017, registrants were 2,294, and then in 2022, it was 2,049. Now, the attendance in 2017 was 9,165, and then in 2022, it was 11,241. Looking at the HB levels these women presented with, in 2017, we got 856 pregnant women having their HBs below 11 gram per deciliter. And then in 2022, we had pregnant women, about 1,868, having their hemoglobin levels less than 11 gram per deciliter. Now to the hemoglobin levels less than 7, which is classified as severe anemia. In 2017, 32 pregnant women recorded their HBs less than 7 gram per deciliter, and then in 2022, it was 69. So you can see the trend in here. It keeps increasing and not decreasing. Next slide, please. And this is a graphical representation of the data. Next slide. Now, the objectives was to look at the prevalence of anemia in the Ejura Municipal Hospital and then the risk factors specific to the setting. Next slide, please. The study adapted the constructs of the biopsychosocial health model by George Angel. And so the risk factors were researched according to the biological factors, the psychological factors, the social and environmental factors. Next slide, please. The researcher conducted a systematic literature review of prevalence of anemia. And then in China, the prevalence rate was 13.9%. Ethiopia was 37.5%. Tanzania, 57%. Nigeria, 37.6%. And in Ghana, 56%. Next slide, please. Now, with the literature review, the risk factors that was noticed to run through all the studies was age, socioeconomic status, family size, and then residence. So ages below 25, the younger ones, and then the older, the socioeconomic status of the families, and then the family sizes. We realized that the high parity in the women with high parity, they were unable to build their hemoglobin levels before they give birth. And so family size was found in most of the literatures to have a significant association with anemia, and then where they stayed. Next slide, please. Now, with the literature review, the biological factors captured was age and infections. And like I mentioned, the younger people and then the older people had an association with anemia. And then infections, which boils down to deprived or restriction in the absorption of iron. Now, the psychological factors captured the beliefs of people. And then the researcher realized that people were aligning their beliefs with the things that they take in, their the nutrition aspect, and then you realize that the things that they decide not to eat because of their beliefs were equally nutritious, which they abandoned, and then it's had an effect on their HB levels. Now, their mood state in pregnancy, the mood swings and everything that comes to play as a result of the hormone display led to some of these women refusing food. And then their behavior, some of them, they have a specific behavior when it comes to food, and then they avoid them, leading to a lower hemoglobin levels. Now, the social factors captured the support. What support do they have in their houses? Are they being supported financially, or are they doing everything themselves? And so we realized that the support was also a problem with these women, and people who were not receiving support in their homes were actually at risk of anemia. And then there were restrictions. Some of these women wake up, do everything in their houses, and even forget about food. Now, midwife-patient relationship. Are these midwives having a good relationship with their clients? If a midwife has a good relationship with her clients, it gives them the privilege to be able to communicate their problems to these midwives. And so when the relationship is bad, these women end up taking their complaints or their problems to their houses. And nobody knows. Maybe at that instant, there would have been a pressing issue that needed care, and we were not able to detect. And then the socioeconomic status, as mentioned earlier. Now, the environmental factors captured the cultural norms as the cultural values of people, restricting them from eating certain diets that will help boost their hemoglobin levels. The health services, the proximity. Do they have a close by health facility to seek care from? The economy of the country. If the economy is bad, money is difficult to come by, and hence leading to low hemoglobin levels. And then the mass media. Pregnant women of these days, of this century, run to the social media, the TV stations, the radio stations for information instead of seeking help from the health providers. And so any information that they see out there, if care is not taken, they take it by first hand. And then this has a great effect on their hemoglobin levels. Next slide, please. Now, the study methods. This study was a quantitative study which used the descriptive cross-sectional design. And the research setting was the Ejura Municipal Hospital. Population was pregnant women aged 15 to 49. And these were women who registered and attended antenatal care at the Ejura Municipal Hospital. This is so because women who registered outside the facility wouldn't have their histories with the facility. And so we concentrated on people they were seeing day in and day out. The sampling technique was convenient sampling, and then the sample size was 394. The data collection tool was, of course, by the biopsychosocial model questionnaire, and then the data collection procedure, a questionnaire was used, obviously. And data analysis was done using the STATA version 17. Next slide, please. The inclusion criteria captured pregnant women aged 15 to 49, pregnant women receiving care at the antenatal clinic of Ejura Municipal Hospital. The registrants of Ejura Municipal Hospital ASA who were fluent in either English or Twi, because that was the languages that the researcher was fluent in. Then the exclusion criteria, pregnant women below age 15 and above 49. And pregnant women who were ill receiving care were also excluded. Next slide, please. Now, ethical consideration was sought from the Ghana Health Service, and that is the number. A letter of introduction and authorization was retrieved from the school and then submitted to the study setting. The BMC of the study setting received approval before data collection started. An informed consent was signed by participants before involving them in the study. Participation in this study was purely voluntary, and participants were assured that their refusal wouldn't affect their care in any way. The researcher ensured confidentiality and anonymity, and privacy was also provided. Next slide, please. Now to the findings. The anemia status in the Ejura Municipal Hospital was 81%, and this is huge. According to WHO, any percentage above 40% retrace that indeed it is a public health concern, and this is what we see. Next slide, please. Now, with the findings, the social demographic characteristics, and then, yes, so the social demographic characteristics led or had a decrease or increase odd with the anemia. though some of them were not statistically significant. But for the biological characteristics, hospital admission increased the odds of anemia by 5.35, and this was statistically significant. We realized that the facility state was a problem, and then most of these wards lacked insecticide-treated nets, and so these women come to the facility and end up going home with a secondary infection, being it malaria or nosocomial infection. And Ejura Municipal is a malaria-prone area, looking at the statistics we saw in the facility. And the women who refused malaria prophylaxis were also at 2.19 increased odds of having anemia. So Ejura is a multi-tribal town, and we have a lot of Muslims in this town. Now, we realize that during their fasting period, these women refuse to take anything in, being it their iron supplements, their antihelmintics, the malaria prophylaxis, and all. And so women who refused this malaria prophylaxis, which helps to prevent them from contracting malaria, and hence leading to anemia and all that, increased their odds of getting anemia. Next slide, please. A slide back, please. Right, thank you. So another interesting finding was the abnormal vaginal discharge. And so if women with leukorrhea comes to describe their discharges and we do not try to assess some of these things, it leads to another thing on its own, which is the abnormal vaginal discharge, which is an infection. And so this led to 3.19 increased odds of having anemia. And then those who experience mood swings, of course, affected their eating habits and all that. Those not statistically significant, they had an increased odds of 1.42. Then the social characteristics, their role restrictions, as mentioned earlier, because of what they do in the houses, some of them end up forgetting about food and end up eating once a day, which is not appropriate for a pregnant woman. And this leads to 7.35 increase odds of having anemia. Then the income per month. Now, women who receive their income less than or equal to 900 cedis were also at increased risk, because the shortages in Ghana sometimes is something that needs to be looked at. And so some of these women come to the facilities and there's absolutely no antenatal books, no antihelmintics, no iron supplements and all that. They have to end up buying them. And so if you are earning less than or equal to 900 cedis, the Ghanaians know that this money isn't something that somebody can rely on for a month. And so they end up leaving gaps in the things that they are supposed to take, which increase their odds of getting anemia. And then the economic effects, when it comes to the economy of the whole country, that is another thing. Next slide, please. Now for the discussion session, 81% prevalence rate obviously is high compared to studies conducted in Nigeria, Ethiopia, South Africa, and Tanzania. Age between 25 to 29, occupation, education, hospital admission, malaria prophylaxis, nutrition, role restrictions, income, economy were some of the factors significantly associated with anemia. And these findings were consistent with studies by other scholars. Next slide, please. Now, the limitation, the study lacks temporal sequence because no causality link was able to be identified. And then the sampling method, convenience, was not robust, and so limits the study. Resource constraints in the fact that the researcher was not sponsored. There was no funding for the study. And I realized that in the community where the study was conducted, there were other facilities that we could look at. Unfortunately, because of resource constraints, we had to restrict to one facility. And so, yes, that is it. Maybe if we had looked at other facilities in the town, it would have added up to the study. And then pregnant women who were learned were given the questionnaires to answer by their own selves. So it's possible that some of them sought online consultation, thinking that whatever they are getting there was the right answer. And the sample size also restricted the measurement of some of the variables. The feedback we got on some of the variables were low, and so we're unable to measure. Next slide, please. Now, conclusion. The prevalent rate is telling us that indeed anemia is a public health concern, it's a burden, and that strategies to address anemia is crucial. Next slide, please. So the researcher recommends family planning so that women will be able to have time to build their hemoglobin levels. We are advocating that women attend preconception care before they get pregnant. In Ghana, most women are not enlightened about the fact that you can seek a preconception care before you get pregnant. And so all you see at the antenatal clinics is pregnant women coming for care and not a preconceptional care. And I am advocating that in future studies, a serum ferritin can be used so that we can measure the iron deficiency in the study setting, which appears to be the major cause of anemia in pregnant women. And then we are advocating that midwives at the study setting can educate their women, the pregnant women, on the risk factors specific to the study setting. Aside from the risk factors, we are also advocating that they do a proper education on the malaria prophylaxis and try to let women understand the need to take the antihelmintics, which, if not taken, equally leads to infection, which will reduce the iron absorption. And then they should also encourage them to use the insecticide-treated nets. So in the town, one interesting thing that we encountered was the fact that they take that insecticide-treated net and they use them in their farms. They use them to protect their produce so that insects do not penetrate. And then their diets, we advocating. Now, this is something I've been talking about for a while now. Midwives should try to take the antenatal clinics to the community, take them to their homes, help them choose food, help them put things together to make the 4-star diet. And then delayed cord clamping. We are telling midwives to educate their women on delayed cord clamping. We are telling them to let them know the benefit of delayed cord clamping so that women can demand that it is done for them during delivery. And then iron supplementation. We are also advocating that they encourage these women to take their iron supplements day in and day out, whether they are fasting or not. They should try and then take it so that they'll be able to build their hemoglobin levels and then their iron levels. Next slide, please. So these are some references. Next slide, please. Yes, so I would like to take this opportunity to acknowledge my supervisors, Dr. Ejura Municipal and Dr. Ivonati, my family, and then the head of facility of the Ejura Municipal Hospital, and then some midwives who came in to help with this project. Next slide, please. All right, thank you very much.
Perfect. Thank you very much, Betty, for this informative presentation. Do we have any questions? You're free to unmute and then go ahead and ask your question, or you can post them in the chat, then we can read them and then Betty will be able to respond. Thank you. Any questions, please? Oh, no questions. I have a question for you, Betty. So thank you very much. I'm very happy that you spoke about delayed cord clamping because that's where we are going to be starting from when we are trying to reduce the lifetime risk of anemia. So for you all midwives that are on this call, please promote delayed cord clamping and start practicing it if you are practicing clinically, because the benefits have shown the reduction of anemia by 60%, the lifetime risk of anemia by 60%. So make sure you are promoting and implementing delayed cord clamping of about 1 to 3 minutes for every birth that you are undertaking. Okay, so here's your question, Betty. So you spoke about Muslim women not taking any drugs during that time when they are fasting. So my question is it possible to involve spiritual leaders in increasing the health literacy levels of women? So if you talk to the Muslim spiritual leaders, they can be able to ensure that the message reaches the women. So is have there been any means, or is there any thinking in this line in which you are to involve the spiritual leaders on the importance of prophylactic medications that women are supposed to take even when they are fasting? Thank you.
Right. Thank you, Dr. Bupe. So this is something that we have spoken about, and according to the midwives in the study setting, they have been talking to these leaders, and the feedback they get is the fact that pregnant women are not supposed to involve themselves in the fasting. But the problem here is that pregnant women feel that even if they don't do the fasting during their pregnant state, they will have to do it after. And that is where the problem is. They do not want to omit the fasting time and then do it later. And that is why they still do it during their pregnant state. So yes, we have spoken to leaders, and they have also taken it up to day in and day out encourage these women and educate them to know why they are not supposed to do this. Thank you.
Perfect. Thank you very much. Any other question? Dr. Apri.
Maybe Dr. Bupe, we should check the chat first from Isabella Garci and the statement from Rehana Rock.
Perfect. Thank you very much, Dr. Apri. So there's a question from Dr. Gati here. So she's appreciating your presentation, Betty. So she said, thanks, Betty. How do these findings translate into changes in routine antenatal or postnatal care in Ghana?
Right. So thank you, Dr. Gati, for this question. I think that making the BMC of the study setting aware of this finding is the first step, so that they will actually implement it in their town. Make sure that midwives are given education specific to these risk factors. And then from there, I think platforms, education on platforms, presentation on platforms, and then we try to invade the policy makers and then see how it goes, so that we will be able to generalize this in Ghana.
Perfect. Thank you very much. There's another question from Dr. Gati again. What would it take for this evidence to influence national anemia prevention and treatment programs? It will be interesting to replicate this study across different settings in Ghana. So that's your question, Betty.
Yes, and so thank you again, Dr. Gati. So presentation of these findings, publications, and then yes, talking to our leaders will go a long way to help to take this message across the country for other people. In fact, I advocated in the research that other people and other settings should try and then replicate the study, so that we are able to know the trend. And then if all are put together, maybe we can conduct a systematic review and then have the actual prevalence of the country. And then maybe we will take it from there. Thank you.
Perfect. Thank you very much. So there's a comment from Rihanna. So hopefully these studies can be carried out throughout Africa, as postpartum hemorrhage due to anemia is still causing loss of lives in maternity. So absolutely. Again, there's another comment from Dr. Gati. So we need to balance a cultural safety with clinical need. Without this, women will seek care elsewhere. We need to design interventions that respect women's choice and respect practices like fasting. Thank you very much, Dr. Gatti. There's a question from Dr. Apri here. So from your perspective, what is one practical step that midwives can take to help reduce anemia in pregnancy?
Thank you, Dr. Apri. So whenever I hear this, I'm always bent on the preventive aspects, because if we are able to prevent it, we won't get to the postpartum stage and then have to manage postpartum hemorrhage. And so prenatally, we will have to educate these women, continue to educate these women. Let's use languages that they understand to be able to let them understand everything that we are telling them, encourage them to take their prophylaxis, encourage them to take the antihelmintics, the ITN, they should use them, their diet, and then take the antenatal care to the communities. In fact, I have issues with why midwives do not engage themselves in these home visits and then leave everything to the public health nurses. Maybe we should deploy midwives, put them in the communities, let them take care to their homes. And then if we keep on doing this, maybe it will change a lot with this anemia.
Perfect. Thank you very much, Betty. So there's a comment from Dr. Gatti again. So well done. Anemia is a serious problem and we need innovative solutions to address it, especially in low and middle income countries. Interesting findings, she said. And then good advice regards to good iron sources available in their communities and